Today, we welcome Catherine Aguinier from SLE. She has been with SLE from 2010, and she's a clinical application specialist. She has extensive knowledge of mechanical ventilation management systems, conventional ventilation, high-frequency ventilation, both invasive and non-invasive waveform, including volumetric capnography, nitric oxide therapy system. She has been responsible for all the aspects of training and education support across Asia, India, Middle East, and North Africa. And she has been instrumental in delivering educational program through lectures, bedside training, and specialized workshops to teams of the trainers and the end users. Today's session, she will be talking about conventional ventilation, where we will be going back to basics. So I welcome everyone. If you have any questions during the training session, kindly put them down on the message and let us know if you have any specific queries, so that we will take it up in the question answer session. And I welcome Catherine, ma'am. Ma'am, over to you, ma'am.
Hello, Rupa. Thank you very much for the introductions. I'm quite impressed, actually. I must say that I'm delighted actually to do a presentation today. I wanted to thank GE Healthcare Wipro to invite me to do the presentation. So they asked me if I could do a presentation on ventilations, and I decided to go first maybe to conventional ventilations, and maybe to go back a little bit to basic, because everything will start from there. So that's why today I will review a little bit some basic. You might know it, but it's always good to have some refresher. So at the end, I think that we will have some time for some questions, and you will be more than welcome to ask any questions. And you can also have some private contact if you want to ask more questions. I hope that it will be interesting for you and that it will be also useful. Oh, sorry, So I will start with the basic knowledge of ventilations. If you have any problem to understand me, or if you have any problem to hear me, just let me know. So the basic knowledge of ventilation. The first thing that we will do is maybe to review a little bit how it works. So whenever we ventilate a patient, what we will do first is to apply a pressure to the patient. But as you will see, is a difference of pressure that you generate that will make the breath. So we will have a pressure difference. The pressure difference will generate a flow, and over time, it will generate a volume change. So those principles you will see will be influenced by different factors that we will view together. So whenever you want to deliver a breath, you have to know what will impact actually the breath that you give to your patients. So what I mentioned to you, that is the pressure gradients that will make the flow, will make a flow going from the patient, from the ventilator to the patients. If you go to this one where you have two compartments and where they are exactly the same, and where you have exactly the same level of water in the two compartments, we guess that the pressure is exactly the same. If I lift up the partition between those two compartments, what I will see is basically nothing. I won't see any flow going from one to the other one. Why? Because I have an equilibrium, and you will have some flow only when you have a difference of pressure, and it will always go from the highest pressure to the lowest pressure. So if you look at my second compartment, where in the first compartment, I have a level of water which is higher than the second one. So it means that the pressure here is higher than the second one. whenever I lift up the compartment, what I will see here, I will see some flow going from A to B to reach the equilibrium. So here, the third one, what I have done is that the pressure here is far higher in my first compartment, in the second one also. But if I lift up the partitions, what I will see is exactly the same flow going from A to B in those two compartments. Why? Because the differential of pressure is exactly the same. So you see, even if you use some pressure which are higher, actually the flow that you will generate is exactly the same, because what generates the flow is the delta pressure. So it's something that is important to keep in mind. So to be a little bit simplistic, we can consider that the lung will behave a little bit like a balloon with a tube. To inflate your balloon, you will blow into the tube, and here you have the balloon which will inflate. Of course, it's very simplistic, so it means that if you have a disease, it won't work exactly the same. But it's just to help us to understand the different principles that we have whenever we ventilate a patient. So the first parameter that you will have is the resistances. We talk quite often about resistances. What resistances are? Is the force which will oppose to the movement of the gas. So what does it mean? It means that if I have a tube here, I try to inflate my balloon, I blow into the tube, and if I blow into my tube here and I apply a certain pressure, it will be how much of pressure I get here. If I have a big tube, the pressure that I will have here and here are quite similar. Not so much difference because not so much rubbing. But as soon, for example, as I use a small tube, if I apply a pressure here, it will get a lot of turbulences because of the small tube, because the flow is high as well, and the pressure that I will get here is lower. Is what you experience when you blow into a straw. When you blow into a straw, you apply a very high pressure, but if you look at the tip of your straw, the pressure is very low. Why? Because you had a lot of turbulences inside your straw, a lot of rubbing, a lot of loss of pressure, and that one is your resistances. So your resistances will depend on different things. It will depend on the size of your ET tube. It will depend on the size of your airways. Smaller is your airways, of course, more resistances. But it will also depend on the flow. It means that if your flow is very high, you will have more turbulences at that time. It's like when you open, for example, a water tap. If you widely open your water tap, you see that the flow is not regular. You have a lot of splashes all around. Why? Because you have turbulences. Okay, so here it will be exactly the same. Whenever your flow is getting higher, you will see that the turbulences will increase. So what will affect your flow is the delta pressure that you set, and also the rise time. We will see this one later on. It depends on the diameter, the length of it as well. That's why sometimes you will see that we shorten the ET tube of the patients. Why? When we shorten it, we decrease the resistances, we will decrease the work of breathing of the baby, and of course, we will decrease also the dead space of the patients. But it will also depend on the density of the gas. So this one is when we provide, for example, some heliox to the patient instead of the air. Why? Because the helium has a density which is far lower, so you have less resistances and is easier for the baby having some asthma fit, for example, to breathe at that time. So this one is a big component actually of ventilation whenever we ventilate a patient and we push a breath. So going back to my model is rather the tube that you use that will generate the resistances or your airways as well. This one is tipping you also that when we read the pressure, we read the pressure here, but it doesn't mean that is the pressure that you have inside your lung. So the second component that you have in your lung is actually the balloon. and the balloon will be represented by the compliance. What the compliance is the change of volume by each increase of 1 millibar of your pressure. Whenever you increase your pressure by 1 millibar, how much of new tidal volume do you add? So if I go to this one, here you will see that I apply a pressure to two different lungs, one which has a low compliance and one which has a high compliance. And you see for the same pressure which is applied, the gain in volume will be different, is what you see here. The low compliant one has a gain in tidal volume, which is lower, even if I use the same tidal volume. So here is seen here as well. So you see for the same applied pressure, my low compliant one has a lower tidal volume. So in the ventilator, what do we monitor is what we call the dynamic compliance. So the dynamic compliance is your tidal volume divided by your PIP minus your PAP. So it's over one breath, how much of tidal volume do you generate? This one is expressed in milliliter per millibar. Quite often we hear that actually is a problem of elasticity of the lung. So compliance, it means that your lung is more elastic or such kind of thing. It's not exactly true. What happened is this one. Here what you see is a lung which is a normal lung. If I take this lung like a RDS patients, I know that the compliance is low, but it's not really a problem of elasticity. What I have is this one. My lung was such kind of lung, quite normal lung. If I push, for example, 10 milliliter in this lung, you will have 5 milliliter each side, and you will see that each alveoli will receive a little bit of tidal volume. Okay. When my compliance is lower, it might be something like that. So here, what I do see is that actually I have a lot of lung collapse. So it means that the part of the lung which is available for the gas exchanges is only 50% of my lung. So what is happening here, I can't put exactly the same tidal volume, because here, if I put exactly the same tidal volume, each alveoli will receive double tidal volume than in the previous one. So basically, is in adults is what we call the baby lung. What means the baby lungs? It means that you have adults, so the size of his lung is adult size, but the part of the lung which is available for the gas exchanges inside the lung of that adult is maybe the size of a child lung. So it's exactly what is happening here. So whenever you have a decreased compliance, it means that certainly the space available for the gas exchanges is getting lower. So here, be extra careful. It explains why when we have a decrease of compliance, we really have to go down on the tidal volume, because here, if I keep the same tidal volume as from the previous lung, what I will do is like doubling the tidal volume of my patient here, because only 50% of the alveoli are taking part into the gas exchanges, are open to the tidal volume. So the rationale behind compliance and to use low compliance is this one. So you see, it's not a problem of fiber, elastic fiber, or such kind of things. It's a space available for the gas exchanges. And we really see it when we do, for example, lung recruitment. When we do some lung recruitment, what do? We go up on the pressure. And when we go up on the pressure, we might manage to open up some alveoli. So when we look at the compliance, here you see at the beginning, you have a lot of lung collapse. So when I increase by 5 millibar here, my pressure, you see the tidal volume is quite moderate. When I go up on the pressure, I have maybe managed to open up some alveoli. I have less lung collapse. You can see that the collapse is decreasing. You see it's decreasing. Here you don't have any more collapse. So you have managed to open up some alveoli, so you have more space to put your tidal volume. And what you see here, for the same gain of 5 millibar, you see that now you have increased your compliance. So why? Because you have recruited some lung. And here, look what is happening. I kept going up on the pressure, and what I'm doing here, I have reached the upper limit of the expansion of my lung. The lung can't expand anymore. I have reached the over distension. So again, if I increase by 5 millibar, now the gain in tidal volume is getting smaller. Why? I went too far. So you see this one, it can help you at the bedside. If you increase, for example, your PIP, you see a gain in tidal volume, a little bit of gain. But when you look at your compliance, you see that the compliance is going down. It tells you that you maybe went too far here. And maybe you should go down to here, because if you go ventilate your patient here, you might injure your patients. So you see the compliance can be a good idea for us. If I increase my PEP, for example, and I see that my compliance is improving, it's tipping me that I have stabilized my FRC. So as you have seen, when I will be pushing a breath, I will need time to inflate my balloon. Okay, so this one is represented by the time constant. So the time constant is the time that is required to reach the equilibrium. So I push 15, for example, of pressure in my ventilator of PIP. How much time I will need to reach the 15 of pressure? So this one depends on your time constants and depends on your resistances. So, and it's exponential. So at first, you will see that is very fast. Then you will reach this one, and then it's going up slowly. So when you have one time constant, you have reached 63% of the equilibrium. And when you have 3 times your time constant, you will have reached 95% of the equilibrium. So some ventilator will display the time constant, but as you see, you can't use the time constant on its own. What you have to do is multiply to have an idea of how much you should use actually for the TI, to determine your TI. But you are lucky enough that we have a better way to know how much time we need actually for the TI. What we will do is to look at the waveform. The waveform for us will be really important parameter to look at whenever we ventilate the patients. So here you have to consider that you have a box where you have 2 compartments. One side is your PIP, is what the ventilator will be pushing, and the other side is the PEP that you have inside the lung of your patients. When the ventilation starts, it means you lift up the partition, and as I explained to you, you will have some gas going from the highest pressure to the lowest pressure until you reach the equilibriums. Once you reach the equilibrium, you have exactly the same pressure in your lung than in your that the ventilator is pushing. It means that you reach equilibrium and you reach 0 of flow, no more flow. And look at your waveform. When the breath starts, remember, it's exponential, so very fast at the beginning, and then is decelerating. So here I have the inspiration, the flow is positive, is going up, so flow going from the ventilator to the patients, and the flow is decelerating until it goes back to 0. When it goes back to 0, it means that you have reached a PIP. So here you are sure that you have given the maximum of tidal volume for the set pressure that you have, PIP that you have set. So here, how I use my TI, I just look at my waveform and I want the inspiratory flow to go back to 0. Why? If my resistances are higher, of course, is like inflating my balloon with a smaller tube. So I will need more time. So you will have something which is flattened like that at that time. and you will see that the flow will go back to 0 later on. So now what we'll do the next step is when the ventilator goes to exhalations, it will go to your PEP. So now you have more pressure in your lung than in the ventilator. So automatically you will have some gas flowing from the patient towards the ventilator. And is what we see here, very fast at the beginning again, and then it will stop whenever you reach the equilibrium. Is what you see again. So the flow is turning negative, your patient is going to exhalations, and very fast at the beginning, decelerating, and here your flow is going back to 0. It means that the patient has finished his exhalation. So whenever I will set my ventilator, I will always make sure that my time constant is sufficient just by looking at my waveform, that I have enough time for the flow to go back to 0. During inspiration and exhalation, very important. So if I look in this one, for example, what they have done here is that they reduced the TI. Look, so the flow is going back to 0, very nice. But here you see the flow is not going back to 0 anymore. So here you won't have the PIP inside your lung. Maybe you can read it at the airways, but inside your lung, the flow is not going back to 0, so it means that you haven't reached the PIP inside your lung here. If not, the flow will go back to 0. And because you stop before the equilibrium, you lose part of the tidal volume as well. So here you see your tidal volume is getting lower. So if you have such kind of figure, if you want to increase your tidal volume, just increase your TI without increasing your PIP, and you will see that you will gain in tidal volume. Whenever you have a pause, it means the flow going back to 0. So of course, you don't have any additional tidal volume going to the patients. So here we pay big attention also to the expiratory flow. Here maybe I have the patient with a quite high CO2. And what I did is that I increase certainly the frequency to try to wash out more CO2. Unfortunately, now I don't give enough time to my patient to fully exhale. And as you can see, the flow doesn't go back, the expiratory flow doesn't go back to 0. So it means that I'm generating some gas trapping, or also what we call auto-PEEP. If we have some auto-PEEP, you will see your tidal volume going down. You will see that your compliance will go down. Your SpO2, of course, will go down. Your CO2 will go up, and you might end up also with a pneumothorax. So very important. So you see, you know already that whenever you ventilate a patient, you don't set exactly the same TI if it's a mass, for example, if it's a patient with RDS. Why? Because in those different patients, in 1.8 kg patients, for example, the compliance will be different regarding the different types of disease. So in a normal lung, your compliance might be around 1, for example, in your 1.8 kg patients, your resistances will be quite low. So here, the time constant that you will need is something like 0.1 seconds. But when you have a chronic lung disease, what happens here? Your resistances will be far increased. You will have certainly a little bit of a decrease of lung compliance as well. And you see that you need a longer TI. But when you have a patient with RDS, here is the other way around. Actually, your compliance in this patient will be very low, and the resistances are quite normal. So here you need a lower TI. And I think that is what we already do whenever you set your ventilator. You have to keep in mind that if you have a patient who has a disease which changes, for example, you have RDS patients, of course, the compliance will be very low in those patients, so you don't need very high TI. But whenever you give some surfactant to your patients, you will go down on the PIP, of course, because the tidal volume will become bigger and bigger. But at the same time, don't forget to readjust your inspiratory time, because your time constant in your patient will have changed. So just look at your ventilator. You remember I told you that the time that you need to inflate your lung will depend also on the flow. So we are quite often confused with the flow, how much of flow we give to the patients. So in the ventilator, you have two types of flow. You have one which is called the base flow. The base flow is a flow which is continuously circulating inside your ventilator. And you have another one, which is your inspiratory flow. And the inspiratory flow is the one displayed on your ventilator when you look at the flow waveform. So you continuously have some flow going to the patient, circulating, inside the circuit, but you have only part of it going to the patient. This one is the inspiratory flow, okay? So the inspiratory flow in the ventilator, you have the possibility of adjusting it. How we do it? We do it by changing the rise time. The rise time here is the time that you will take from the PAP to reach the PIP. So how fast you will go. If you look here, I change it from a rise time of 0.04. So you have only 0.04 to push the piston of your ventilator to deliver your PIP. And now I'm telling you that you have far more time. You have 0.28 seconds. So if you look here, you see the waveform has changed because the increase of pressure is more smoother here. And you see, it affects your flow. You can imagine that in the first one, I gave you a balloon and I gave you also a syringe. And I told you, you have to push a syringe, but you have to do it within 0.04 seconds. So if you put push a piston of your syringe very fast, it will generate a very high flow. If I tell you you have 5 times more, you have 6 times more time to do it, what you will do at that time, the flow, you push the piston more slowly and the flow will be decelerating, will be lower, is what happens. Why is it important? It's important also. So, of course, you will need more time to deliver the tidal volume at that time. It's important because we know that we have a risk of injury if we use a flow which is too high. That injury is called reotraumatism. Okay, so we have some doctor who advise to keep the peak flow in the tiny baby below 4 liters per minute. If you want to change it, don't forget to change this one and just make sure you see here, because you need more time, I should increase a little bit my TI because the flow now doesn't go back to 0. So this one is the different parameters that you have to consider whenever you will start ventilation. You have to think of the compliance, of the resistances, the delta pressure, those different parameters. So when you start the ventilation, you will have different aims. When we ventilate the patients, it can be because we have an oxygenation problem, so we want to maintain the oxygenation of the patient. So how to achieve a proper oxygenation of the patient? One of the first parameters might be the FO2. If your gas is richer in oxygen, of course, you will deliver more oxygen to your patients. But very important parameter which will affect your oxygenations is the PEP. The PEP, it's the one which will keep your lung open. So you remember the image of lung recruitment that I showed to you is that when I was increasing the pressure, of course, what will happen, I was doing some lung recruitment. But if I go back to the initial pressure, what will happen? My lung will collapse again. So the PEP is the one which prevents the lung collapse. Then, of course, you need appropriate tidal volume, and that one will be delivered through the PIP, and also a proper time to deliver it. In some disease, you might need to recruit your lung, because if you have a lot of lung collapse, as one of the pictures that I showed to you, even if you increase your FO2, if you increase your PEP, you might not just have enough alveoli available for the gas exchanges, and then you can't get proper gas exchanges. So it's what we will do for oxygenation. The second thing that we have to maintain when we do some conventional ventilations is to maintain a proper ventilation of the patient. So this one will help with the clearance of the CO2. So what is it? It's the alveolar minute ventilation. Is how much of gas reaches actually your alveoli per minute. So here is the rate time your tidal volume minus the dead space. The dead space is all the part of your tube, your ET tube, such kind of things, your airways, which don't take part into the gas exchanges. So your VT, again, is influenced by different things. It depends on your setting, the delta pressure. It depends, as you have seen previously, on the flow. It depends on the TI, because if your TI is too short, you might not reach the tidal volume that you want. It depends on the frequency as well. And of course, it will be affected by the compliance and the resistances. So it's a tricky thing, because when we ventilate the patients, we have to avoid different things. So the first thing that you have to avoid is the electrotraumatism. What is it? Is whenever you increase the pressure, when you have a collapsed lung, you might have some alveoli which open up with certain level of pressure. So they open up very nice when you increase the pressure. Okay. The problem that we face with those alveoli opening up is that they don't gently open up. They burst open. And when they burst open, they will generate a lot of inflammation and a lot of injury and a lot of release of chemical substances, which will be injurious for the lung. So you can imagine that if they open up when you go up on the pressure, one is when we went down on the PEP level, the PEP wasn't sufficient enough to maintain my lung open. So again, when I go to the PIP, it's opening up and bursting open again and generating some inflammation and going. So this one, the atelic traumatism, will be avoided by setting a proper PEP. You have to avoid the barotraumatism, not too high pressure. At the same time, you have to avoid oxidative injury. You know that oxygen is toxic for the lung. So you are perfectly aware that if you use too high oxygen FO2, you have a risk of ROP, but you know also that you have increased risk of BPD if the patient are exposed to higher level and longer time also of high oxygen. At the same time, so your tidal volume must be big enough to ventilate the patient, but at the same time, you should avoid too high tidal volume. So we keep a very close eye on the tidal volume because we have some studies to support that one. One of the studies which was very nicely done, it was done by Dreyfus in 1985, where he took 3 batches of rats. One batch of rats was ventilated with high pressure, generating high tidal volume. When we look at the lung of the patients, they noticed that they had a lot of inflammation, a lot of injuries actually in the lung of the patient. So then they took a second batch of rats. And what they did at that time, they used low pressure, but the low pressure was generated against some high tidal volume. And when they look at the rat, again, they had a lot of albumins, they had a lot of extravascular lung water, which means that they had a lot of injury of the lung. The third batch of rats, what they did, they strapped the rib cage of the rats. So they push a very high pressure high pressure inside the lung, but because of the strapping of the lung, of the rib cage, the lung couldn't fully expand. So the tidal volume which was generated was smaller. And what they noticed is that in those lungs, they still had some injury, they still had some inflammation, but far lower than the previous one. From then, we said, okay, we have to be careful with the tidal volume. So you have to ventilate your patient where you avoid the atelectasis. This one, it will be with your PEP, and at the same time, you avoid the over distension. So be careful with your PIP. So the PAP, do we set the same for all of them? No, because you will have different kind of lung disease. So the aim is to prevent some atelectasis. When you lie down, for example, you have the weight of your heart, which might induce a little bit some lung collapse. So we will always leave a certain level of PAP when we ventilate a patient. But at the same time, if you have a disease where you have a lot of atelectasis, like for example, RDS patient, you might need a quite high level actually of PAP to keep your lung open here. But at the same time, if I have a patient who has a primary PPHN, those patients, if I use a high PIP, I will injure, because I don't have any lung collapse. What I will do here, I have a risk of over distension. I have a risk to increase the resistance, the vascular resistances at that time, and even worsen the situation. So the PAP that I will apply to my patient will be different regarding the disease. So what about the PIP? My PIP is the one that I will change to generate higher delta pressure, to generate my tidal volume. So as I mentioned, I should avoid over-distension and volutraumatism to avoid dead space as well. So the dead space ventilations will change. The tidal volume, the alveolar ventilation, you remember, is the tidal volume minus the dead space. So my dead space will change with the age of my patients, and it will change with the disease of my patients as well. So if you look at this one, here is a maturation of my lung. If you see, at first, when you have a 24 weeks patient, for example, you have mostly alveolar ducts here. So it means that you have a lot of airways and very limited number of alveoli. So your dead space is quite limited, is quite high. And then when your patient gets older and older, of course, you have more and more alveolar sacs which develops. So the ratio of airways compared to the alveoli is changing. So that's why when we look at the recommendation of Kessler regarding which kind of tidal volume we should deliver to the patient, you will see that actually in your very preterm patient, RDS patient, where we think that we should use something like 4 milliliter per kg, will be higher. We will be something like 5.5. Why? Because here you have a patient where the dead space anatomic dead space is higher. And also because the flow sensor that we will put, the ET tube also will add a lot of dead space compared to the size of the patients. So in those patients, we will go higher on the tidal volume. We might go around 5.5 to 6 milliliter in our smallest patients. When the patients are becoming bigger, so here they are older, they have more developed lung as well. And here the dead space also of the flow sensor will be less important for those patients. And that's why here we will go rather for your RDS patient to 4.4 to 4.5 milliliter per kg. Now, if I look at my patient, for example, here if I have a term baby, but the patient has a congenital diaphragmatic hernia, why I'm using 4 to 4.5 is just because I have a hypoplasic lung. My lung is smaller than a normal one. My compliance is lower. I have to go lower on it. But if you look at this patient, the patient has a severe established BPD. What do I know of the disease? I know that in the BPD, advanced stage of the BPD, I have the change of the anatomy of my lung, and I know that the airways of my patient are higher. The diameters of the airways are higher, so it means that my dead space is more important. That's why also I will ventilate my patient with higher tidal volume. Here, my resistances are also increased. When I ventilate the patient with low tidal volume, with low compliance, so we will use low tidal volume in low compliant lung, But because we have a low compliance as well, it means that the recoil if I don't have any problem of resistance, the recoil will be very fast, and I will be able to manage my CO2 washout by increasing the frequency in those patients. So here, just to give you an idea, it was shown that in adults, in RDS patients, that not only the use of low tidal volume was important, but also the use of the delta pressure. And what they found out is that in patients who were ventilated at 6 milliliters per kg, which are the recommendation for adults in ARDS patients, is that they could discriminate two types of patients. The one which were ventilated, who were ventilated with a delta pressure superior to 15, and the one ventilated with a delta pressure below 15. And what they noticed is that if they were delivering 6 milliliters per kg, using a delta pressure of more than 15 milliliters, they had actually a death rate which was higher than if the delta pressure was only 15 or below. So the conclusion of Amato, who did the study, was maybe for those patients, the 6 milliliters per kg was already too high, and maybe we should have used a lower tidal volume for those patients. So it means that if you have to deliver 4 milliliters, but you use a very high delta pressure, I would switch at that time to HFO. Okay. So when we come to conventional ventilation, we have different modes. We have CMV, SIMV, PTV, or pressure support. So it means that you take over the respiratory center of the patient. So here you will have to determine different parameters. Of course, the PEP that you start with. How to start the breath? Do you start a breath? You set a number of breaths, and it's a time trigger. Is it a patient who will start the breath? Do you synchronize with the patient? Then the second parameter that you have to set is how far you go, how much of PIP. Do you set a tidal volume that you want? This one. Then you will have to say when to stop the breath, because you take over the respiratory drive of the patient, you have to set all those ones. So here, when to stop the breath? Do you want after a certain time? Do you want when the flow goes down to a certain point? So here is the parameters that you will set. The PEP to prevent the atelectasis, to avoid the atelectasis, to make sure that your lung is kept open, that you keep a proper FRC. Be careful, not too high. If not, you will increase the work of breathing. You will set the rate, the TI, for all the modes that you have seen. Of course, the PIP to generate a tidal volume, or maybe a targeted tidal volume whenever you work with TTV or BTV. Your FO2, trigger sensitivity whenever you will be working with synchronized mode, and of course pressure flow termination whenever you will be using pressure support. The first mode which was developed in ventilation was CMV, very, very rigid mode, too rigid mode. That one, it just does what you have set. You have set a frequency and the PEP, PIP, TI. So the ventilator said 30 breaths per minute, every 2 seconds, I will push a breath going from the PEP to the PIP for the TI. The problem that you face is that it doesn't synchronize with your baby. And don't think that your baby doesn't breathe when you are in CMV. If you look here on the waveform, what you see is a lot of fluctuation of your PEP. Why? It's because my baby is taking some spontaneous breath. Here, the baby, you see, I told you when the flow is getting positive, it means that the flow going to the patient. When it's turning negative, it means that you have some flow going from the patient to the exhalation, to the ventilator. So it means that my patient is taking some breath. And when I look here, I perfectly see that my patient is taking some spontaneous breath. But the problem that I face here is that here my patient took a breath. You see the drop, you have a drop of pressure, patient drops the pressure, flow going to the patient. So the patient took a breath. Okay, fine, patient takes a breath. But what happens is that ventilator says, oh, time for a new breath. So what he's doing is pushing a new breath on the top of the breath that the patient is taking. So here what you see is that you have a bigger tidal volume. So what have shown the studies here is that whenever you use CMV, if your patient has some spontaneous, what you will see that your blood gas won't be very good because your ventilator, the patient will be fighting against the ventilator. So it means more work of breathing for him, risk of gas trapping, higher risk of pneumothoraxis. At the same time, we know that whenever the patient is fighting against the ventilator, we might damage the diaphragm of the patient as well. So to me, CMV, we should forget that mode. We shouldn't use it at all anymore. You will see that SIMV can be a very good mode for you if you want to control the number of breaths that you want to deliver to your patients. So when we look back at the different studies where they compare all the modes where you had the mode which had some synchrony with the patient, they were performing better than the one than CMV, where you don't have any synchrony. So now, how do we synchronize with the patient? If I want to use a mode where I synchronize with the patient, I definitely have to set a trigger. When you use the ventilator, the SLE ventilator, and you have the flow trigger, automatically you will be using a flow trigger. So it means that the flow trigger is a green line that you see here on your ventilator, on the flow waveform. When the patient takes a breath, what he does? He drops his pressure. When the pressure drops, differential of pressure in the lung of patient is lower than the one that you have in the machine. So automatically you have some gas going from the highest pressure to the lowest pressure. That's why you see some flow like that going here. When the trigger, whenever the flow crosses the green line, the ventilator will know that the patient is taking a spontaneous breath, and the ventilator can synchronize with your patient. So, but you might have some problem. Like here, what happens? I see that my patient took a breath, the inspiration, the exhalations here, but you see the effort that the patient did was too small actually for the ventilator to reach the flow trigger. So the ventilator doesn't pick up the breath of the patient. So here, even if you are in PTV, ventilator can't pick up the breath, so you will have some asynchrony. So what I have to do is always to make my trigger sensitive enough, to drop it, to make it sensitive enough to pick up the breath of my patient. At the same time, I have to be careful that it doesn't pick up some artifacts. What is happening here? I have a patient with very high leak. I know it because what I see here, you see the flow doesn't go back to zero. It's stabilizing here above zero. It means that I have a leak, and my leak here is very important, and the ventilator is compensating for the leak. And what is happening is because it's compensating for the leak, the flow is crossing my trigger, and the ventilator keep pushing some breath. I have some auto triggering. If I see that, what I have to do here is to go up on the trigger. Okay, so here I will go from 0.4. I have to make sure that it goes above the flow line here whenever at the end of the exhalation. Okay, so be careful if you use a very low trigger because you have a risk and a high level of leak. Is that why we don't like leaks? Because you have a risk of auto-triggering. The other factor which might give you some auto-triggering is whenever you have a lot of water in the circuit. When you have water in the circuit, you see you have some artifacts with the flow moving like that, and you might have at one point of time the flow crossing the waveform here, crossing the flow trigger, and the ventilator might think at that time that the patient is taking a breath and push some breath. So be careful with water in the circuit, with very high leak also in the patient, because you might end up with some auto-triggering if you have set a very low level of trigger here. So usually we set it at 0.6, and we will, in this patient, if it was at 0.6, I will decrease at 0.4 to make sure that it picks up the breath. Be careful if you go down to 0.2 because you have a higher risk of picking up some artifacts. The second mode that you will have, and the first one, which is synchronized, is PTV. So PTV stands for patient trigger ventilation. That one is equivalent to assist control mandatory ventilation, or is equivalent to SIPPV. It means synchronized intermittent positive pressure ventilation in other ventilator. So this one, it will be the similar. You will set the number of breaths. So this one that you want, you set the PEP, the PIP, similar, the TI as well. What difference you have is that you set a trigger, because here the ventilator will synchronize with your patient. What will do the ventilator is each time that the flow will cross the flow trigger, each time the ventilator will push a breath. Which kind of breath it will push? It will push a breath which goes from the PEP to your PIP for the TI that you have set. Automatically, no limitation. If you set a rate of 10, but your patient is breathing at 50 breaths per minute, the ventilator will push a 50 breaths per minute. Okay. What happens if your baby stops breathing? If you set 30 breaths per minute, for example, it means that the ventilator is expecting a breath at least every 2 seconds, 60 seconds divided by your 30 breaths per minute. So if the ventilator doesn't see any breath for 2 seconds, it will just take over. So then it will take over and push a control breath. If 2 seconds later you don't have any breath, again, it will push a breath. So it means that the patient will receive at least the frequency that you have set. But if your patient is breathing at a higher rate, then the ventilator will synchronize with all of them. No difference on the waveform between your control breath and your synchronized breath. I know that it's in synchronized breath. Why? Because when the ventilator picks up the breath, it turns orange. So the waveform will turn orange. So what do we know? We have some doctors who are a little bit reluctant to use PTV because of this study. So the study, we look at PTV versus CMV. And what they noticed is that in very preterm patients below 28 weeks, they noticed that they had a higher rate of pneumothorax when we were working with those patients. But if we look carefully at the study, what we will see is that actually the settings that were done for those two modes were completely different. That might explain why we had such kind of difference. How to use it? So what has been noticed is that we should set, if your patient doesn't have good spontaneous, we should set a rate which is sufficient to wash out the CO2. If the patient doesn't have good spontaneous one. But if the patient has already a good spontaneous, be careful with that. Don't set a too high frequency, because we have a study to show us that when we set a very high rate, 50 breaths per minute, for example, to compare to 40 or 30 breaths per minute, we will see a decrease of the spontaneous breath of the patient. The ventilator, the patient will just rely on the ventilator. Okay, so here he will make less effort. And for us, it's very important to maintain the spontaneous of the baby. Why? Because once a patient is taking a spontaneous breath, it keeps training his muscle, his diaphragms. So here, no immobilization of your diaphragm, keeps working with the diaphragm, keeps the strength of the diaphragm for the breath. And at the same time, we know that whenever we push a breath, actually, when it's a controlled breath, the gas will go more to the non-dependent part of the lung. Whereas when we have a spontaneous breath, the repartition of the gas actually inside the lung is more even. So it's better to have a spontaneous breath. So what we will do, if I have a patient breathing, for example, at 40 breaths per minute, I will set a backup around 30 or even lower. So, but always keep an eye, make sure that you don't have any auto-triggering. So when you wean the patients, if your patient is doing mostly receiving some spontaneous breath, no need to decrease actually your frequency, because all your breaths are triggered by the patient. If you want to wean your patient, just decrease the PIP. Then if you want your patient to take over, he has to do more work of breathing. How it will do more work of breathing, it is how we do it. Okay. So The other mode that you will get is the pressure supported mode. So this one is similar to PTV, exactly the same as PTV. The only difference is your terminations of the breath. How does it do it? It just is flow cycle. So as I mentioned to you previously, is that when the ventilator pushes the breath, you will have a flow which goes very high to the peak flow, and then the flow will be decelerating. So to 80% of the peak flow, 60% of the peak flow, 40%. And what you will set here is how much of deceleration, at which level of flow you want to stop the breath. Why is it interesting? For different things. What we will see is this one. When the patient takes a breath here, what happens? My patient takes a breath, he will drop further his PIP, the flow will go higher, you see, and then the time to go to 5%, for example, to the flow termination will be longer. So if you look here when my patient is making a small effort, you see the flow is going lower, and here, the time to go 5% is here. If I ask you to take a deep breath, automatically you will hear that the flow is going higher, and automatically your inspiratory time will be longer. So here you allow the patient to control his inspiratory time. It's very interesting and it's physiological. But also what is important, you remember the time constant I mentioned to you. The time constant, the time that you need to deliver the breath will depend on your resistances and your compliance. Look, your waveform will change. Here, what is happening, I have a patient who has a problem of resistances, so I'm trying to inflate my balloon with a small straw. Here, what is happening, and the peak flow will be lower, and it will take a long time for me to inflate my balloon. So what is very nice here is that you see now, to reach a 5% is actually longer. So automatically my TI is adapting to my patient lungs. And similar here, where I have a problem of compliance needs less time for this time to deliver my tidal volume. And as you see now, my tidal volume here, my TI will be shorter. So what is very nice is that you will see your TI changing with the effort of the patient at the same time that you will see it changing with the lung mechanics of my patient, adapting automatically. So why do we have also a TI max? Is because in some patients, when I have a leaks, you see, it doesn't reach the criteria that I want. I wanted 5%, but it will never reach a 5%. So then what I will tell my ventilator to do is to make sure I want my patient, the ventilator, at that time to terminate my breath when it will reach my TI max. So I tell the ventilator, whatever you reach first, the flow terminations that I have set, the termination sensitivity that I have set, or the flow, my TI max, you stop the breath. So we just have to be careful with the TI max. The TI max is a pressure that will be used whenever the patient stops breathing. If the patient stops breathing, ventilator, you remember, will take over, will push a breath, and this time it will use the TI max to stop the breath. So here, I just have to be careful, because if I set a TI max which is too short, you see here, I reach a TI max before I have the time to go to the 5%. So if I go to this one, sorry, can you see my video? You see here is very short. If you look here, my TI doesn't change. It's always a fixed one. I increase my TI max. You see now the flow has time to go down. And now I have some fluctuation. What happened at first was this one. Look carefully. You see here, I reached my TI max before I had time to go down to the 5% off. So what the studies are saying regarding pressure support? We have a nice study where you had some patients who were ventilated in SIMV, switch then for the same period in pressure support, back to SIMV and get back to pressure support. And what was noticed is that the tidal volume that was delivered to the patient during the pressure supported phases was always higher than the one delivered during the SIMV. So they concluded that it might improve actually the lung mechanic of the patients. The third word that you might be very familiar with is SIMV, Synchronized Intermittent Mandatory Ventilation. That one is a nice one because what it will do, it will also support the breath. It will synchronize for the breath, but only for the breath that you have set. So if I look here, for example, I set 30 breaths per minute, so I know that I should deliver a breath every 2 seconds. Okay, here. And what will do the ventilator, it will try to synchronize with the patient. So say, okay, if my patient takes a breath, it's not exactly the 2 seconds, but we come near the 2 seconds. I will have a kind of window where if my patient trigger a breath here, I will synchronize and push a breath because I know that it's near the time where I should push a breath. So is what will be happening here. The ventilator will synchronize with your patient only for the number of set breaths that you have. So here is what we are doing. So here you see your patient, you have the SIMV breath, ventilator synchronizes with the patient. Here your patient takes a breath and ventilator say, too early here. No, I don't push any breath. But you see your patient is taking your breath, no problem with that. And here your patient takes a new breath, say, okay, it's time for a new breath here. When you look here again, the patient takes a breath, ventilator said too early. But here this time the ventilator said, okay, we are not at 2 seconds. We know that we are not 2 seconds, but we are coming near the time. So here I take advantage of your spontaneous breath to synchronize with you. And like that, I will have less asynchrony. So you see, if you was using CMV, actually, before thinking, oh, I want to deliver only the number of breaths that I have set. Don't use a CMV where you have some asynchrony, very high risk of asynchrony. Use SIMV because the ventilator here will push the number of breaths that you have set, maybe a little bit more than the one that you have set, but you will be very close to that one and you will avoid at the same time some asynchrony. But be extra careful at the same time, because when you look here, what is happening, your patient is taking some spontaneous breath, and here he doesn't have any help from the ventilator. So it means that the work of breathing, you have to suck a breath through the ET tube might be quite high. Okay, here. So what you might see here is that if your patient is the CO2, what you have generated here with your SIMV is not enough to wash out the CO2, what will do your patient? He will take some additional breath to try to maintain his CO2. And if he doesn't have the strength, if it's too difficult, he will take some small tidal volume and very fast rate at that time. So what you can do at that time is those one, you give them some pressure support. So then you are in SIMV plus pressure support. So what you have added here for the pressure support is the pressure that you want to reach for the pressure supported breath. So your PIP of the pressure supported breath will be 12. And here you have to set the termination sensitivity. So in between your SIMV breath, whenever your patient is taking your breath, here is pressure supporting. So you will decrease the work of breathing of your patient. And this one is shown actually in the studies where they compare SIMV to SIMV plus pressure support. And what they saw is that they were decreasing the number of days of ventilation. So the exposure of also of ventilation to the patient when they were combining SIMV plus pressure support. So this one, you have to be careful because it's more complex when you win the patient. You might decrease the rate, you might decrease the PIP of the pressure support, the PIP. So be careful because here it might take more time to win the patients. I think that pressure supported and PTV are some modes that you can use right from the beginning to extubations. Don't always think to SIMV that we see widely used. Why to give a big breath at one time, small breath at another time? If you want to train your patients, if you want to see if your patient is fit enough to breathe, just go to PTV, decrease your PIP, and see what is happening. Is your patient is able to generate proper tidal volume? Okay, so it means that he has to make more effort. Can you win even more your patient? Is a question that you will be asking. So the last one will be a little bit faster, is not really a mode. That one is something that you can combine to all the previous mode, is targeted volume ventilation. Just briefly, what is targeted volume ventilations? Before, normally what you do at the bedside is when you start your ventilations, you have in mind the disease of your patient, the weight of your patient. For example, you have a 2 kg patient, RDS patient, you will have in mind, I want around 4 milliliter per kg, so I should deliver a tidal volume around 8 milliliter per kg in this specific patient. So you will start maybe at 515, for example, of pressure, and you see how much of tidal volume you get. And then you will titrate your PIP until you get your 8 milliliter of tidal volume that you wanted to deliver to the patient. Whenever you use VTV, or targeted tidal volume, or volume guarantee, you will set how much of targeted tidal volume you want, and then the ventilator will do your job. It will titrate the PIP to reach the tidal volume that you want. But as you do at the bedside, you don't know exactly how much of pressure you need to reach your tidal volume. For the ventilator, it will be exactly the same thing. So it will maybe increase a little bit your PIP, see that it doesn't reach yet the tidal volume. So next time it will increase again a little bit your tidal volume, your PIP. So the ventilator is doing what you do at the bedside by adjusting actually the PIP to deliver the tidal volume that you want. And what we want is the exhaled tidal volume, which is equivalent to your targeted tidal volume. Does it do better than you? No, it doesn't do better. It's exactly the same. So quite often I hear that VTV, VG, they use the lowest possible pressure, they use the lowest possible pressure and what, no. It's not that. What is doing the ventilator is just selecting the pressure that is required to deliver the tidal volume. If you turn off VTV, if you needed 15, for example, of pressure to deliver your tidal volume of 8 milliliter, if I turn off VTV and manually I had to set my ventilator, I will have to set 15, exactly the same one. Okay, so what you have to be careful with is to set proper TI and proper tidal volume for the patients. When we use VTV in the SLE ventilator, if you use VTV, you can use it up to a leak of 50%. But frankly speaking, I wouldn't use 50% of leak. Why? Because we know that the monitoring is becoming less accurate when we use when we have very high leak. So I will minimize my leak and I wouldn't use it for leak which are higher than 30%, because we know that we lose in accuracy. We have some estimation after and not a real reading. So don't use it with leaks which are very high. We should minimize the leaks when we work in conventional ventilation. We don't use it in when we have some air leaks of gas trapping. When the ventilator compensates for leaks, it always assumes when it sees that you push a tidal volume, for example, of 10 milliliter and you get only 8 milliliter, the ventilator will always assume that the leak is at the ET tube. So what it will do, it will increase your inspire tidal volume to get the 10 milliliter of exhale tidal volume that you want. Your target is 10. Okay, but if you have a problem of gas trapping, what happened? The patient really receives the 10 milliliter, but you had 2 milliliter which stayed in the lung. So here the ventilator doesn't know it. So the next breath, what he will do, it will be pushing 12 maybe of tidal volume. So here, don't use it. Don't forget that if we don't set properly the tidal volume, it won't be long protected. So we have to be careful with how much of tidal volume we set. So this one will again depend on the weight and the disease of the patient. What we will set also is a PIP max. The PIP max will be really the upper limitation of the pressure that will allow the ventilator to use. But similar than you, it means when you start your ventilation, you have no idea of how much of pressure you should use. So what we will do, we will use a PIP max, which is a little bit high, maybe 23 in our tiny babies, and then we will readjust it later on. So what we will do, the ventilator will look always at the last tidal volume, which exhale tidal volume, and then we adjust the PIP to get whatever you want. But you have different regulations. One of the regulations is that the ventilator will increase or decrease your PIP regarding how far it is from the target. The second thing that you might see sometime is that your tidal volume is too big. So what does the ventilator? It will decrease the PIP, but the minimum delta pressure that the ventilator will deliver is 3 millibar. It won't go below 3 millibar. Why? Because if we go below, it will be like a patient on CPAP. And you never leave a patient on CPAP, intubated patient on CPAP, because you know that you might exhaust the patient. So we leave a minimum of 3 delta pressure to make sure that you don't increase too much of work or breathing of the patient. Okay, so but you can come and you see that you have 3 millibar of tidal volume, but your tidal, you see that of millibar of pressure and then of delta pressure, and your tidal volume is too big. Why? So the first question that the first thing that I will think is that my compliance is quite good. Okay. The second thing that I will ask is why I have a tidal volume is too big. Look at my patient. Is it because my patient has some spontaneous breath? Yes, patient has some spontaneous breath. Does it mean that I can extubate my patient? The respiratory drive of my patient is fine. Maybe the pressure is quite low now. I don't have any fever. I don't have secretions. Every parameter are okay for weaning. Maybe I can extubate my patient. What is happening is that my patient, when he takes a spontaneous breath, is already exceeded the tidal volume that I have set. So the first question that I will ask myself. The second question will be, okay, my patient is not extubable, can't extubate my patients. So should I increase my tidal volume? Is the tidal volume that I have set is actually too low for my patient? It's something that I have to consider. If my tidal volume I consider that is not too low, should I sedate my patient? Because it will be the only way for me to stop the spontaneous of the patient. So just to let you know what you can see on the ventilator. If the tidal volume is really too big, actually, and if the inspire tidal volume is 2 times your targeted tidal volume, the ventilator won't wait the end of your TI to go to exhalation. As soon as it reaches, it will go to exhalation. So then, if you go look at your ventilator, you might see that the delta pressure is 3 millibar and that your TI is shorter than what you have set. Okay, so then you have to ask a previous question. Whenever whenever we ventilate the patient, when the patient you have reached the pressure, the tidal volume that you wanted, you look at how much of PIP the patient is using, and then you will readjust your PIP max by putting your PIP max, which is around 2 to 3 millibar above the one that is currently using. Why? Because the 2 or 3 bar will allow you, if your patient has a little bit of secretion, the resistances increase a little bit, you need a little bit more PIP to deliver the same tidal volume. If you turn your patient on the side, maybe the compliance will change a little bit, then again, the ventilator can go a little bit higher. But if you have a very important problem, for example, I don't know, selective intubation, if you have a pneumothorax and that the ventilator needs to increase a lot your PIP, you won't be alerted if you don't have the PIP max telling you that the tidal volume is which limits the increase of PIP. So it's very important to see this one. So here we have, so the Cochrane review here have shown that actually when the VTV was certainly one of the modes which was showing a benefit compared to the other mode. The other mode, we don't see really any difference when we look at the studies. But when we look at VTV, they managed to see that they had a decrease of BPD at 36 weeks of gestational age. The rate of pneumothorax, which was lower, the mean days of ventilation, which was lower, the rate of hypocarbia, which was lower because your tidal volume is stable, so you maintain the stable CO2 washout as well. And we didn't find any negative outcome with VTV. But keep in mind that you are the one, if you don't set a proper TI, if you don't set, for example, a proper tidal volume, you won't have any benefit. So you have to set also the proper tidal volume for those ones. The last one that I wanted just to mention to you regarding conventional ventilation, one thing that is quite often overlooked is your alarms. Your alarms to me are very important. Tidal volume will be the first alarm which will tell you that something is wrong. For example, you have a problem of resistances, a lot of secretion, a problem of ET tube which is not in place, a kinking of the ET tube, the bronchospasm, any problem. If you have also tidal volume getting lower, maybe you have some lung collapse after suctioning, maybe you have a tidal volume, for example, which is going too high after surfactant because we didn't go to down on the PIP, I don't know, selective intubation, your ETD tube moved, everything. The first parameter will be your tidal volume. So don't forget the tidal volume alarm, which are very important. The respiratory rate can show you also the support. If your support is not sufficient, for example, you will see the respiratory rate going higher. Okay. PIP, PIP will tell you also the leaks if you have some problem with those one. And the leak for me should be maintained to the lowest possible. Okay. So, okay. So just to give you just an overview of the modes that are available, the different things that you have to pay attention to. So whenever you ventilate a patient, you have to ask yourself a number of questions. Which kind of disease you have? So for the disease, which kind of PAP you should use? Then the tidal volume that you should deliver to the patient. How much of tidal volume you should deliver? The question will be regarding the age of the patient, regarding the weight of the patient, the disease of the patient that you have. When you set the ventilator, be cautious with the TI. The TI will change as well. So you have to navigate in a zone which is difficult for you, but each patient, I know that a lot of people are frustrated when we don't give any value. We don't tell the people you should set a PEP at this level, a PIP of this level. Or why we can't tell you is because it should be titrated for each single patient. So with your experience, you have a better idea why you should start, which the value we should start with, but then you will always titrate the different parameters. So thank you for your attention. I'm sorry it was certainly too long, as usual. I hope that it was interesting. Rupa, sorry, is your microphone?
Thank you, Catherine. It was a wonderful session. So we have received some wonderful questions from our esteemed audience. I would like to, put those questions forward to you. So our Dr. JT has asked, which mode is better in case of neonatal ventilation, whether it is PTV or SIMV? And also, how much should be the volume that needs to be set in case, a volume guarantee mode is used? So approximately a rough idea, I guess, doctor has asked. So how do they do the volume setting in VTV mode?
Okay, so thank you for the question first. So this one, what I will say, which mode is the best for you, is definitely the mode that you know very well. Yes. Because you should, whenever we change a setting or we change a mode, we should actually know in advance what will happen. So if you are not comfortable with the mode, is maybe not the mode that you should use. So we see a lot of different practices. If I travel, for example, here in Europe, where I'm based, we see a lot of units using pressure support and PTV. A lot of doctors will use PTV because some doctors they don't want some breaths which are supported at different level. They consider that all the breaths should be ventilated at the same level. Okay. Yeah. So it's as usual not really an answer for you, but I mean that if you're not comfortable with the mode, don't use it. If you're comfortable with the mode, use it. But the practice here in Europe, we will see mostly PTV use, pressure support ventilation also use. And they will usually start from the beginning, being very cautious always with the trigger, not to have any auto triggering. So for example, if you are in a unit where you have a lot of problem of water, for example, maybe is not a solution if you have a very high risk of auto triggering. But if you manage properly, I would say any mode except CMV.
All right.
Then regarding the tidal volume is what I mentioned to you regarding Kessler. I can send it to you. The one will be really regarding the disease that you have and the weight of the patient. So tinier is your baby is what I showed you, that when you have a baby who is below 700 grams, you know that the dead space in those patients are higher. So anatomic one and the one that we add also due to the ET tube, due to the flow sensor. So that one for those patients, we will use a tidal volume, which will be more something like 5.5 to 6 milliliter per kg, even if it's a severe RDS. Whereas when you go to the bigger patients, I will go for 1 kg, 1.2 kg, rather to my 4 milliliter. Then again, look at your compliance. If, for example, you have a patient who has, for example, when we look also for the mass, when you have meconium aspiration syndromes, you have different types of patients. You have some patients where you have like RDS almost because you have a lot of collapse inside. For those patients, even if my mass is a term baby or post-term baby, even so usually quite big baby, I might go to 4 milliliter per kg in those patients if I have the image where I have a lot of long collapse, because I know that the size available to receive my tidal volume is actually getting lower.
Okay. All right.
And look, you can look also at the compliance. Look at your compliance. What is happening if you increase too much of tidal volume? Is your compliance going down as well?
You look at your baby and you make decisions. Okay.
Look at all the information from the ventilator. It will give you some tips.
Yes. And next question is from Dr. Dinakar, who has asked us, please tell us about rise time and what are the normal values that we need to set in this case?
So I can't tell you very precisely. What you will do is, for example, the rise time, we don't touch it too much. Usually, we leave it. But if you see, for example, that the rise time, the flow is going fast, too fast, for example, for your preterm baby, where you want only something like 4 liters per minute, don't want to go above that one, I will just go down on that one to make sure that the flow doesn't go too fast at the same time. But keeping in mind that, of course, if the flow rise slower, it means that I will require more time to reach the equilibrium. So I might need to increase my TI as well at that time.
Okay.
Be careful if it's too low. it might be uncomfortable as well. So you want it to reach a little bit of plateau and then go down, not too fast.
Not too fast. Okay. So another question is, what is the difference between infant ventilator and universal ventilator? Somebody, our team also wants to, understand the class.
I don't know if you remember the flow, what I showed to you, that you have a continuous flow in our ventilator. All the neonatal ventilator will have continuously some flow circulating in the ventilator, is what we call the bias flow. So it doesn't, you remember, it doesn't mean that it's the flow going to the patient. Why do we have the continuously some flow circulating in the ventilator? Is that you can't stop the spontaneous of the baby. The baby might breathe at any time, but you are working with very tiny baby. So what happens is that whenever you have the flow, when the patient exhales, it will take away those small breaths, and you are sure that you don't have any gas rebreathing. And if the patient wants to take a breath, he's not breathing against nothing, like a closed valve, where he can't get any gas. So that's why in infants is to make sure that you wash out properly the CO2, that you don't have CO2 rebreathing. And at the same time, it means that you always have some gas which is available for your patients who are tiny patients.
Okay, thank you. And one important question was asked by Dr. Pradeep. He says that in premature babies, fixation of ET tube is very difficult, and these move continuously, causing either displacement or injury. So what is the solution? The tiny ET tube also keeps getting blocked frequently, and the suctioning or cleaning is not practically possible. So what to do in this type of situation where you want data and also that there is a lot of block which is happening? So he wants.
Okay. So this one is really depend on your nurses. So maybe we are quite lucky here in Europe where we have quite some system which allow us to have some nice fixation actually of the ET tube with very gentle tapes that we will be using. It might not be available or maybe quite costly actually for India. I can understand that it can be very tricky for you. So this one is, but this one is something that we have to work with the nurses to make sure that whenever they handle the patient, that they really keep the ET tube fixed, maybe to have somewhere where you not exactly where you have the repair, where you should have your ET tube, for example. But this one, I think, is something due to the education of the nurses, when we have to be careful whenever we manipulate, maybe to be two people if required, to make sure that it doesn't move. So we shouldn't see so much dislodgement of the ET tube when we manipulate the patient if we do it properly normally. The other factor is the suctioning. So the suctioning depend on the kind of patients that you have. When you have RTS, normally the secretion are not thick at all. Something that's so here you will do some just à la demande. So it means that only if you see maybe some secretion in the tube, maybe if you see some your resistance is going up, your tidal volume going down, for example, you will do some suctioning. But you have maybe to do it if you have a patient who has some very sticky secretion. The first thing is that we might use also a tube, a catheter, which is a little bit bigger to make sure that we get proper suctioning, and we might have to do at that time on a regular basis for those patients. But this one is related, it will be case by case. We will suction the patient only on requirement most of the time, especially RDS, because we don't have so much secretions. But if you have a patient with a pneumonia, maybe you need to suction more your patients here.
Okay, so some of the questions specifically from the medical colleges, some of the aspiring doctors have asked about non-invasive high frequency also.
Okay.
understand basics of that as well. So just a few points, on non-invasive high frequency maybe.
So we have a second session, and the
Yes.
second session will be on non-invasive ventilation, and I will, at that time, I will talk about it. So if you don't mind, I just reserve to the second session where it will be dedicated to non-invasive ventilation, because I think that is really important to avoid intubation as much as possible, and the non-invasive, the new non-invasive modes that you have available now might help you actually to avoid the intubation. So it's a very important topic.
Better for babies.
Yes.
So thank you, ma'am. It was very informative session, and I would also, thank our audience for, for their participation. And I'm sure that our audience have benefited by today's session, especially on setting of the parameters, and also how to select the modes and how to select and set the parameters on that. Please note, audience, the webinar link that we have shared, this will remain the same for our next training session also, which is on the November 2nd. And it will be at the same time, 7 p.m. to 8 p.m. And kindly save this link and save the date of November 2nd. And as ma'am has already informed, it will be on non-invasive mode of ventilation. The indications, the contraindications will be discussed during that session. And thank you for your participation. The recorded, the recorded video of today's session will be definitely available on YouTube in GE Healthcare India site. And we would definitely love to hear from you. How did you find our session today? So do leave us with your feedback. Thank you. Thank you, everyone.
Thank you very much. Thank you to all of you. Just keep an eye on the waveform. Very
sure. Thank you, everyone.
Thank you very much for organizing everything, and thank you very much for your attendance.
See you all on November 2nd.
Thank you, Rupa. Thank you. Goodbye.
Okay. Thank you, ma'am.
Recording stopped.